Diabetes is on the rise. No longer a disease of predominantly rich nations, the prevalence of diabetes is steadily increasing everywhere, most markedly in the world's middle-income countries, so states Director General of WHO, Dr. Margaret Chan, in the Global Report on Diabetes published in 2016. Latest figures from 2012 shows that diabetes caused the death of 1.5 million people and led to an additional 2.2 million deaths caused by higher than optimal blood glucose, which increases the risk of cardiovascular and other diseases. 43% of these 3.7 million deaths happened before individuals reached 70 years of age. Diabetes is probably recognized as one of the biggest global health challenges in the 21st century, and according to the Global Report on Diabetes, it is estimated that 422 million adults were living with diabetes in 2014. These numbers equal a fourfold increase since 1980, or a rise from 4.7% to 8.5% in the adult population affected. The prevalence is rising in all income groups. However, as you can see in this graph from the WHO, over the past decade, it has risen faster in low and middle income countries rather than in high income countries. WHO divides the world into 6 regions: the Americas, Europe, Eastern Mediterranean, Africa, Southeast Asia, and Western Pacific. The largest number of people with diabetes were estimated to reside in Southeast Asia and Western Pacific regions. In total, 3/4 of people living with diabetes live in low and middle income countries, and most of them have only limited access to treatment. According to WHO, we then find the highest prevalence of diabetes in the Eastern Mediterranean region and the lowest prevalence of diabetes in the African region and the European region. But why is Europe that low when diabetes used to be the most common disease among affluent populations? Christine Feerk, Senior Researcher of Clinical Epidemiology at the Danish Steno Diabetes Centre, may provide us with an answer. So why are we seeing a lower prevalence in Europe?
First of all, I think it's important to say that it's not really a low prevalence we see, but it is lower than in the other regions. I think that one of the reasons could be that in the other regions, people have been better to have focus on diabetes and being better to diagnose and identifying people at risk during recent years. So in Europe, many countries have had action plans. For instance, in primary care, I think there have been a lot more focus on diagnosing diabetes and also managing risk factors for both diabetes and cardiovascular disease, like obesity, smoking, hypertension, and focus on physical inactivity also. Then there has also been implemented policies in many countries, for instance, increased taxes on tobacco, and unhealthy foods, and also there has been limited advertisement for unhealthy food also in televisions and so on. So I think these policies and action plans may have played a role. And additionally, urban planning and improvement of infrastructure, for instance, securing bike lanes and so on in the cities, which make it easier to live healthy, I think that has played a role in many of the European countries.
So so from a European level, we've been trying to be proactive with lifestyle changes, with taxes, promoting infrastructures to encourage people to be healthier. That's really what you're saying. But what are the main risk factors that we're facing here in the European region?
Well, obesity is one of the most important risk factors. More than 50% of the European population actually have overweight or obesity at the moment. And we know that obesity accounts for up to 80% of diabetes risk. So that's really a focus area. Also, we have shown in studies that where we follow people for up to 20 years, that just small increases in body weight is actually associated with development of type 2 diabetes. And we see then in more than 90% of those who develop diabetes, they are actually only slightly overweight. So even though you're not obese, just being overweight is a risk factor for diabetes.
So obesity is one risk factor. What about physical inactivity?
Yeah, physical inactivity is a huge problem also in relation to diabetes development. And we know that we have been more inactive during the last decades, and 80% of adolescents are actually not living up to the physical activity recommendations. So there's a lot of things we have to do there. We also know that if we can make people at risk changing their lifestyle, being more physically active, they can actually reduce the diabetes risk by up to 60%. We know that in people who have impaired glucose tolerance, which is a pre-diabetic state. But we still need to have more knowledge about how to motivate people to become more active.
I'm really interested to know your view on diabetes in Europe in the next 10 years. Where is it going?
I think we will have more focus on both prevention and health promotion in terms of preventing diabetes and other non-communicable diseases in 10 years. On a population level, I think we will see more focus on structural prevention, so like the city planning and so on. And also I think on an individual level, we will have more knowledge into the heterogeneity of type 2 diabetes, because we know that type 2 diabetes is not just one disease. Every person have his or her own kind of type 2 diabetes, and we need to take into account both physiological factors, sociological factors and so on in terms of preventing and treating diabetes in the right way. And I think we will have more knowledge into that area in 10 years.
So what you're saying is actually more personalized medicine.
Exactly.
In the sense, could you just explain a little bit what personalized medicine means?
Yeah, but it means that you, for instance, on the physiological level, you can measure a lot of different, both risk factors and also metabolites in the body, and you can use that information in predicting how this person will react or respond to different treatment options. And also, I hope you can be better to use that also in terms of preventing diabetes. So people at risk may not need the same kind of prevention. Some people may benefit a lot from physical activity, where others may benefit more, maybe from some dietary interventions. So I think we'll know more about that in 10 years.
So the risk of diabetes, is it different between different ethnic groups in Europe?
It actually is. A recent study we did from Denmark, we did a study at Steno Diabetes Center, showing that migrants from Asia, Africa and the Middle East actually have 2.5 times higher risk of diabetes compared to native-born Danes. So there is a difference between ethnic groups within a country and also between the countries in Europe.
So why is that?
That's a really good question, and we don't really know the answer. But I think we will need to look more into whether the disease mechanisms differ between people with different ethnic backgrounds in order to also be more aware if we should stratify prevention and treatment of diabetes between the different ethnic groups.
It is likely diabetes rates in Europe will continue to rise for years to come, and it's not surprising that the rising curve is associated with being overweight and low physical activity in this region. What is surprising, though, is the fact that while diabetes rates rose steeply over the past 3 decades, the affected population has changed. What was once considered a problem for rich countries has now become a problem disproportionately affecting poorer countries. And perhaps even more surprising, type 2 diabetes is becoming increasingly common among people with a normal or underweight body mass index, which is BMI, and it is no longer a disease most prevalent in urban areas. This means that even though diabetes will rise in urban areas, it will rise even more steeply in rural areas in developing countries. We are currently witnessing an increasing number of people in rural areas in both low and middle income countries who will suffer from diabetes. How and why is this happening? As yet, science has no answer, but Venkant Narayan, Professor of Global Health and Epidemiology at Emory Global Diabetes Research Center in Georgia, Atlanta, may be able to shed a little light on this. Greetings to you, Venkat. Welcome to the discussion. Could you explain to us why diabetes is on the rise in rural areas in the low and middle income countries?
Yeah, when you travel around the world today, you understand that the forces of economic change is very powerful and very pervasive, and it's now even touching the rural parts of developing countries. And with this, there's been major shifts in lifestyle, particularly mechanized transportation, mechanized labor, loss of physical activity, higher consumption of processed foods, higher consumption of refined carbohydrates, foods very low in protein, and very little consumption of fruits and vegetables. So when this happens in the context of populations who are susceptible to type 2 diabetes, it's not at all surprising that we should start seeing a rise in the prevalence of type 2 diabetes, even in the rural parts of the developing world.
So which population groups are affected?
Now, what is really worrying is that in many developing countries, such as India, several parts of sub-Saharan Africa, type 2 diabetes is affecting people at very young ages and even at very low BMIs that you might consider as normal or even underweight. People born into countries that are coming out from centuries of undernourishment, poor maternal and child nutrition, seem to be particularly vulnerable to this kind of type 2 diabetes, which is affecting young people and at low body mass indices. It's really the combination of poor quality early nutrition, perhaps when the child is in the mother's womb or during the first few years of life, plus modern lifestyles which are low in physical activity, poor in the quality of nutrition, combines together to double the risk for diabetes in these populations.
Does there exist a scientific explanation to why these population groups are currently affected by this increase in diabetes?
The problem is most of the science that we have today has been concentrated mainly in the developed countries of the world. And we have very little data in low and middle income countries which are undergoing rapid transition and experiencing this huge increase in diabetes, also in people who are thin and underweight. So we can only try and speculate from the available data. It appears from the few data that we have, it appears that people who have been exposed for generations to poor quality nutrition, maternal and early child nutrition, probably have two problems. Firstly, they have a propensity to store fat around certain organs, even when they are thin, and this increases what we call insulin resistance, or in other words, it impairs the action of the hormone insulin. But in addition, our data also suggests that these populations may also have poor insulin secretion to start with. So you have this double problem. One, which impairs insulin action, and the second, not having the capacity to produce enough insulin when there is a metabolic load. So when these two combine together, you start seeing a very high risk of type 2 diabetes and very rapid conversion from normal to prediabetes and from prediabetes to diabetes.
How did we start to realize that this was also affecting low and middle income countries? What was the tipping point, or what was the data or the research that gave us this information?
Well, I mean, essentially, small studies about 10, 12 years ago started highlighting the fact that type 2 diabetes prevalence, even in rural parts of countries like India and Sri Lanka, was beginning to be high. We conducted a systematic review of all available good data from rural parts of low and middle income countries, and what we have seen really is a quadrupling of the prevalence over the last 25 years. So exactly where it started, we do not know, but clearly a phenomenon that has been accelerating over the past 2 decades.
Combating diabetes is a huge and complex challenge, strongly linked to poverty, poor nutrition, and other aspects of social and human development. As an important cause of premature death and disability, it has become one of the 4 priority non-communicable diseases, commonly named as NCDs, targeted by the world leaders in the United Nations Sustainable Development Goals to reach by 2030.